Hello friends, my name is Dr. Saif and welcome to my YouTube channel. I'm an ICU expert and today I'm going to talk about the anticoagulant use during the renal replacement therapy. So as you know that renal replacement therapy is required in about 20 to 25% of ICU patients who develop acute kidney injury. Alright, so to prevent filter clotting and to prevent the uh, to improve the lifespan of circuit and filter used in renal replacement therapy, you require anticoagulant. All right, because there is an exposure of blood to the extracorporeal circuit during renal replacement therapy, which promote the clotting, and this is why an anticoagulant is used to prevent clotting. Now, anticoagulant which we use during RRT may not be needed in some forms of renal replacement therapy. For example, intermittent hemodialysis or sustained slow low efficiency dialysis, that is called SLED, or this is a type of PIRRT. Because of shorter duration of renal replacement therapy and higher blood flow, these two factors decrease the clotting risk, and this is the reason these two modalities do not require the anticoagulant. Whereas in CRRT, especially the convective modalities such as CVVH and CVVHDF, these two modalities definitely require the anticoagulant to prevent the filter clotting because of higher hemo concentration in the filter. Circuit clotting is the most frequent cause of therapy interruption in CRRT. It also adds to increased cost of therapy due to frequent hemofilter changes and circuit changes. The ideal anticoagulant is the one which is safe and having maximum efficacy, that is anticoagulation. Also, it should have a short half-life and have an antidote for easy reversal. So these two characteristics are very important for an ideal or optimal anticoagulant. So for the anticoagulations, we have two options. The first option is the systemic anticoagulation, which is very commonly used, and another option is the regional one. So for the systemic anticoagulation usually is done by infusing unfractionated heparin. Only issue is the bleeding risk. In patients with hemoglobin drop, heparin is often discontinued in ICU wherever you are suspecting abdominal bleed or cerebral bleed, you have to stop the heparin infusion. Or if there is hemoglobin drop also, you sometimes stop the heparin infusion in such cases. So here comes the role of regional anticoagulation using trisodium citrate solution. The risk of systemic bleeding is minimal with this technique, and here citrate solution is infused into the bloodline immediately before the filter, thereby chelating the calcium. Okay, and the citrate is metabolized to bicarbonate in the liver. Because citrate is principally cleared by the liver, patients with impaired liver functions or shock, in such conditions citrate will accumulate and will result in high anion gap metabolic acidosis. And also there is problem of hypocalcemia because of systemic calcium chelation. And finally that will result in an increase in the calcium infusion rate. And this may be very complex because you never know when calcium level is going to drop, and you have to adjust the calcium gluconate infusion rate very frequently. So that is very complex and require frequent monitoring. Systemic heparin and RCA are effective at preventing clotting. If you talk about which is better, so I would say both are having the same efficacy as far as prevention of clotting is there. So both can prevent a clotting definitely, but if you look into secondary outcomes such as the filter lifespan, that is going to be more with the RCA. So RCA has two major advantages over heparin infusion. The first advantage is the extremely low risk of bleeding. So that is safety. So RCA is safer compared to heparin infusion. Another advantage is that it has less chances of circuit clotting and less chances of, blood transfusion requirement, because circuit clotting means that you have to change whole circuit and there will be definitely hemoglobin drop in such cases, and that will lead to blood transfusion. The second advantage is more important, and that is the superiority of heparin for the filter lifetime or filter lifespan. The filter lifespan can be increased from for 26 hours to 47 hours if RC is used in place of heparin, as has been confirmed in recently conducted trial, and that was the RICH trial, RICH trial, which confirmed that RCA provides longer filter life than systemic heparin anticoagulation during CRRT in critically ill patients. This is a recently done large trial, a properly done trial, and it definitely showed that there was a increased lifespan about 47 hours from 26 hours, and the secondary outcomes like mortality were actually equal. So that was thing, but that this trial was underpowered to show any difference or any change in the secondary outcomes like mortality. The main drawback using citrate as anticoagulant compared with heparin is the need for calcium replacement and the rigorous control of calcium levels, as we have already seen in previous slides. So this is the main drawback, and that is why RCA is not very popular. Because of the complexity inherent in RCA, current guidelines recommend its use in CRRT only for patients without shock or liver impairment and only by centers with an established RCA protocol. Okay, because few centers may be very comfortable using RCA. So only those centers guidelines say that it should be practiced. In case you are not able to use anticoagulation in CRRT, there are few non-pharmacological interventions to prolong filter life. These interventions are interesting. For example, pre-dilution filtration that might improve the filter lifespan compared to the post-dilution technique. And as far as the access is concerned, access and catheter types that also have some bearing upon the outcome like filter lifespan that may improve the filter lifespan. For example, non-tunneled catheters have been found to be better compared to tunneled catheters. Regarding access, right IJV access was better compared to left, and compared with short catheters targeting tip placement in the superior vena cava, long catheters arriving in the right atrium may prolong the filter life. So these are few non-pharmacological methods. Another one, the coating with polyethylamine coated AN69 membranes having less thrombogenic. So this is another type of a special coating which is less thrombogenic and will lead to improved filter span. All these interventions are actually uh, having actually not being tested in the trials, so they are having some value but still needs to be tested. So if your center is using RCA, an expert in it with an established protocol, continue using it. Otherwise, you can use just heparin infusion. That is good enough. Okay. So that's all for today. Thank you very much for your attention.